Hi, I'm Kelly Arthur with Health Quality Innovators, and today I am in Calvert County, Maryland with the Calvert CARES program team to discuss their program and how they decided what they were doing, how it's funded, and how it can benefit and possibly be replicated in your facility. This is a continuation in our segment of Ideas That Work series. Karen, could you start by telling us a little bit about how you decided on this program and how it operates?
Absolutely, thanks Kelly. So Calvert CARES is a program that is focused on activating resources and empowering patients to manage their own care. It's a multifaceted program that has evolved over the last 3 years to include nursing as well as pharmacist, social work, and physician in varying roles within the team. The program was initially brought about as a result of issues that were identified by patients as well as the community, where we really felt we could partner better in helping patients self-manage their care. We did look at the Coleman model. We visited another facility in the state of Maryland, Western Maryland Health System, to see what they were doing, and we took best practices from both of those programs to begin developing our program. It initially started as your traditional transitions to home program with nurses doing coaching calls and home visits, and has now evolved into a team comprised of those nurses as well as a pharmacist doing coaching calls and home visits, our physician seeing patients in our clinic, along with social worker, pharmacist, and nurse.
So patients are referred to your program via your, how do the referrals come to you?
Sure. Referrals can come to us through our inpatient and outpatient case managers, as well as any of the providers in our community. We've also really focused on our partnership with our local healthcare coalition. So specifically, skilled nursing facilities and home health agencies have been a great source of referrals for us.
Dr. Knowles, can you tell us what you see as a benefit and how this program has been successful for you?
Well, I think just to carry on with what Karen said previously, I think coming from both an inpatient and outpatient model previously, having worked in both of those areas, I think what this clinic and transitions team does very well is that we take all the best parts of an inpatient care team that's invested in getting the patient through an acute illness period and bring it to the outpatient setting. And that really has been invaluable in helping people who previously, for one reason or another, having difficulty meeting their healthcare goals. What we have here is we look at it from not just a physician-centric piece that most outpatient practices have traditionally done necessarily, and taking a fresh approach to it. So we have a clinical pharmacist who's going to sit there and look at why have patients been unsuccessful in being able to be compliant with their medication regimens, and that can come from any number of processes. It's really FOM has been invaluable in making them really help them with their literacy, if you will, with their medication regimen, make it practical. In the same way, our social services team looks at what are the psychosocial and often financial barriers that are impacting patients being able to be compliant with their care. If we don't address those needs, then ultimately we're not going to be successful.
So
that's been invaluable.
In the program, to address the patient as a whole and fit the program around your patient, then with your social worker you are looking at even social determinants such as the transportation issues and the medication issues that Karen references, TAP and MAP, but also food insecurities, income circumstances, to better prepare the patient to take care of themselves. And I know, Fonba, you do even home visits with some of the patients. So can you elaborate on how you choose which patients that you're doing home visits for and what that home visit entails?
To pick a patient that goes for home visit, most of those patients must have their primary care. They already have primary care physician. They have more than 9 medications, and they have mentioned during the admission or during their stay at the hospital at one point that they're having difficulty with their medication, then I will step in, see them home if needed, or bring them to the clinic. Sometimes from home, I bring them to the clinic to see exactly what I can do for this patient to solve that piece that the patient mentioned at the emergency room or during their stay at the hospital, and what else I can do. And you'll be very surprised what I see when I go to that home.
So you're looking at potential adverse drug events, medications that might be expired, or it's the wrong dose, or it's a duplication. So you're making a comparison of all the medications for the patients.
Just yesterday, I found a medication that was expired 15 years ago.
15 years ago.
Yes.
So Karen, just quickly, I understand that when the patients come into the clinic, that they spend at least an hour with each of the 4 disciplines. And I'm just wondering, you said that the hospital has funded a lot of what the program does, but how are the patients paying? I mean, is there a fee for the patients that are coming into the clinic?
Great question. The hospital does pay for the program, and we have paid for it through seed money that we've gotten from the state of Maryland under our waiver payment system, as well as incentive money that we received over the years. And that's what has allowed us to provide all of these services free of charge to our patients. We don't charge for anything. We don't bill any insurance companies for anything.
We would like to thank the Calvert CARES team for spending the time with us to help bring their program to light and allow you an opportunity to reach out for further information, because this is another idea that works.